our Executive Director for Public Health, is going to introduce this to us. Diolch, Mes.
Diolch, Cadeirydd. Pnawn da. So I'm pleased to present to the board the annual report of the Regional Partnership Board, more commonly referred to as the RPB. So as members are aware, the RPB partnership brings together health, social care, PAVO and wider partners to work together to improve outcomes for residents. And the annual report outlines the activity to deliver the agreed joint area plan, which forms part of the 10-year health and care strategy, A Healthy Caring Powys. And the report highlights the projects and services that have been delivered under the agreed priorities of Start Well, Live Well, Age Well partnership groups, which sits under the governance of the RPB board. So the RPB board is chaired by our vice chair, and the RPB exec group is chaired by the Director of Social Services and Wellbeing. And both Kirsty and Nina may wish to add to this item today too. The annual report has been approved by the RPB at its board meeting on the 10th of June and is being presented here today for assurance of the continued joint work and participation through the RPB partnership to address shared challenges, working within the agreed planning and governance frameworks. For awareness, the delivery plan for 25-26 will be considered at the next Planning, Partnership and Population Health Committee, due to be held in August. Diolch, Cadeirydd, thank you.
Diolch yn fawr i chi, Mes. I think Nina isn't with us. She did inform us earlier that she had to go to a council commitment this afternoon. As you said, Mes, Kirsty is chair of the RPB. If you do have any additional comments, or please come in, Kirsty, but you may or may not have.
Well, thank you very much, Chair, and thank you to Mes. I just wanted to put on record my thanks to Jo Wellard, who is the RPB Chief Officer, supporting the collaboration, and just to say that I'm very grateful to all the colleagues at the Health Board who work in the partnership space in the true spirit of partnership, looking to find collective solutions to enhance the health and well-being of the people of Powys alongside their colleagues from social care and the voluntary sector. Our legal duty is one around cooperation, and I feel, having witnessed the work firsthand, that we fulfil our responsibilities in that regard very well. Thank you.
Thank you, Kirsty. And just to say as well that certainly the forward look, the forward plan of the RPB will be considered in more detail by our PPPH committee, our Planning, Partnerships and Public Health Committee, when it next meets in August. So this will receive more detailed scrutiny within that meeting as well. But colleagues, do indicate if you would like to make a comment or ask a question in response to this agenda item. Ronnie, please.
Thank you. This is not a question, but an observation. I just want to say what a very clearly constructed and very readable report this is. And on that basis, I commend it as an exemplar. I think that's all I need to say, Carl. Thank you.
Thank you. Appreciated. And is there anyone else that would like to comment? Yes, please, Mick.
Thanks, Carl. It's there's lots of difficult and challenging things on this agenda. It's quite refreshing to read something positive. Some really good initiatives in there. Quite clearly creating employment for people, providing services which people clearly value and benefit from. But I'm just very conscious that we live in very uncertain times. Forthcoming elections, potential political changes, financial pressures. So I was just wondering how the RPB plans to sustain those initiatives beyond the current funding cycle. We quite often see these things built up. People come to rely on them, both for employment and for service. And then, if the funding situation changes, all that is then put at risk. So I just wondered if how the partnership is planning for that.
Mez, would you like to respond?
Yeah, thank you. So as part of the work during the last sort of 8 to 9 months, we undertook a prioritisation and an evaluation piece of work led by the RPB coordinators, but involving Partnership Office and myself from the Health Board as well, where we reviewed all programmes and services delivered. And as part of that, a component of the evaluation was sustainability plans for projects to develop robust sustainability plans. Some had robust plans, others needed to be strengthened, and that is work that continues into this year. We are mindful currently funding is until March 2026 elementarily, and over the next sort of few months and into next year, we will be currently strengthening that as well. But it will be obviously a challenge for some of those services that have been embedded as part of our sort of network. And we will need to look at that as a health board for some of those programmes that are funded through that route as well. I think Kirsty wants to come in as well.
Yeah, just to give assurance, Meg, at the board, we have stressed the need for the projects to have those very clear sustainability and exit plans that Mez just talked about. That's an important part of the governance that we look at in terms of the robustness of the projects. I think what we also need to do is to recognise that in some cases it may not be possible for those projects to continue. And indeed, under the current RPB arrangements, we've had projects that have come to an end for a variety of reasons. And where we cannot sustain a project because an organisation doesn't become embedded either into our work or into the work of the council, that we actually are able to capture the learning from that project. So even though the project itself might not be able to continue in that current form, actually what we have learnt, what we have gained from that project looks to support developments in other organisations. So ideally, some projects would be, rolled in to the bottom line of organisations, but given budgetary constraints, that's really challenging. But where it's not, we do look to ensure that learning and experience is captured to inform policy developments and initiative developments in other organisations.
Thank you. So let's move to the recommendation, and that's that we receive the RPB annual report and forward plan, and that we take assurance that the RPB is fulfilling its role and providing an effective mechanism for delivery of the joint area plan as part of the 10-year health and care strategy, A Healthy Caring Powys. Once again, if you don't support the recommendation, please indicate. That is supported unanimously, which takes us to item 3.10 on our agenda, which is the Equality, Diversity and Inclusion Annual Report. And the Executive Director for People and Culture will introduce this item. Thank you, Deb.
Prynawn da, diolch, Chair. Just to let board know, I'm also joined by Dr. Adam Pearce, who is our Welsh Language Equality, Diversity and Inclusion lead, and he'll help support this item or any technical questions. So once again, we're pleased to present our Equality Annual Report. A key focus for us in this year has been the development of our anti-racism plan and its recent revised version, which was approved by board, and all of that aligns with the Welsh Government's vision for an anti-racist Wales by 2030. The cover report sets out some of the highlights which are contained in the report in more detail. Just as a summary and as a snapshot, we're very proud that we've achieved the age-friendly employer certification and the first stage of the disability confident workplace certification, as well as rolling out many of the activities associated with our Speaking Up Safely framework. These initiatives, along with many of the others, contribute towards our goal of making Powys Teaching Health Board an employer of choice for people of all backgrounds. Whilst the work in our Better Together programme and through public health teams helps address the inequalities amongst the population we serve. We can also see in the report that we have undertaken a detailed analysis of the workforce data from a range of perspectives and a reporting on ethnicity pay for the first time, alongside our regular statutory reporting of gender pay. This research is built on our response to the Workforce Race Equality Standard, and we're in close contact with colleagues in Welsh Government, and some of that has helped to inform our actions in this financial year. As with our previous annual reports, if approved by board today, the report will be translated and published on the internet. I'm happy to pause there and open it up for questions, Chair. Thank you.
Thank you, Deb. A croeso, Adam. Dwi'm yn gwybod os gen ti ryw sylw ychwanegol ti eisiau rhannu. If you have, just inviting Adam to offer any additional observations before opening it up to discussion.
Na, dim diolch.
Okay. So thank you very much for, once again, a really helpful and comprehensive report. Ian, you'd like to contribute. I hope your audio works. If there we are, we can at least see you.
Yeah. Okay. Can you hear me?
Yes, we can.
Fabulous. Thank you very much. I'm having some bandwidth issues here today. Thanks very much, Chair, and thanks very much for this report. It's very thorough. It's also it's got a lot of very pleasing things. I think, you know, the things we are achieving around equalities, it gives me a great level of satisfaction. I was particularly pleased to see in the introduction the work we're doing around age-friendly and also as well in terms of people with hearing impairments as well. And as I belong to both those groups, obviously I have a vested interest there, but it is really, really pleasing to see that we are making some major steps forward. My question is around the award that we've received, the Bronze Award we've received from Diverse Cymru. And I was just curious as to whether we were embarking on a wider programme with Diverse Cymru, because I'm conscious of the fact that they offer organisations such as ours a great deal of support around diversity and involvement. And I just wondered whether we were progressing work with Diverse Cymru or whether we were just you know, drawing a line under it with the Bronze Award.
Just to come back on your first observation around kind of hearing and age friendly, just as a reminder to everybody, when we did our strategic equality plan, what we heard from staff, what we heard from the public is that we needed to prioritise a few areas, and they were age, sensory loss and neurodiversity. So we are trying to funnel a lot of our work on that. I'll ask Adam to come in on the Bronze Award, if I may.
Thanks, Deb. Yeah, I was going to say that if you didn't, so thank you. Yeah, it was the areas identified by the consultation. So yeah. So with regards to the Bronze Award, so that was an achievement by the midwifery team. The way the scheme, that particular scheme works, is it's an assessment of a workplace. So they wouldn't. It's not an assessment of Powys Health Board as an employer, because they work with sort of workplaces of typically between sort of 5 and 20 people is their kind of, rather than a 2,000 person workforce. There was absolutely nothing stopping other workforces in Powys from sort of enrolling on that program, and it's an option that we presented to you know, you know, when they come to us and ask us about you know, what are the options on the that we have. You know, the feedback from maternity on that course has been really positive. You know, I suppose the only thing to bear in mind, of course, is that there is a cost associated with undergoing that, and of course, you know, that's something to be mindful of when individual departments are looking to undertake that.
I think the short answer is we'll continue to review it, and whether that becomes viable for all of the organisation or other workforce teams.
That's great. Thanks very much. Thank you.
Thank you, Ian. So I can't see that anyone wants to ask a question or contribute. So once again, thank you for the report. The recommendation is that we approve the Equality Annual Monitoring Report for publication on our website, and once approved, that the report will be made available in both languages publicly. Therefore, I'd assume that that's approved unless anyone wants to indicate to the contrary.
I think we've got a couple of...
Thank you. That is therefore approved unanimously. We turn our attention now to the minutes of our previous meeting of the 21st of May. Initially, for accuracy, are there any corrections, amendments, or changes that anyone would like to suggest? No, and therefore we accept those as a correct record of our last meeting. Thank you. I'm assuming that there are no other further actions. We have already considered the action log earlier in our meeting. So item 3.12 on our agenda is the financial performance report for month 3, and we go back to Pete to present this report. Thank you, Pete.
Yeah, thank you, Carl. So as introduced, this is the finance report as at month 3. Just to say that a number of issues that are highlighted in the report we've already covered when we discussed and went through the annual plan presentation earlier. So what I will do, I'll go through and I'll identify the key issues, and then we can open up for a bit more time for questions and comments if that's okay. So as I run through the report, as at month 3, we're currently reporting a £8.494 million overspend against a break-even position. In relation to our current forecast plan of £28.3 million deficit, that would have had us at a position at £7.078 million overspent in month 3. This means that we have an adverse position of circa 1.4 million against that 28.3 million deficit plan position. The main reason for this deficit is that, or this variance from that deficit plan, is that one, we know that the action we're taking around our commission services are not going to have an impact until July from Q2 onwards. This is included in a straight line profile in our position. That is the largest part of the reason for that variance. Also noting that there is a shortfall against our £23.1 million savings target. As reported earlier, we're currently at 18.2 against that target. That is also a shortfall in the position. The position also reflects the cost of a number of risks, which I'll come on to later. If I just continue to run through the report, on page 4 of the actual report itself, there's a summary of our key expenditure areas and the current position as monitored against that £28.3 million deficit. In that position, the key areas to flag are: 1, the commissioning services position, as I've just highlighted, and secondly, ongoing pressure in relation to the use of private providers in relation to mental health services. Continue to move through the report, there is an analysis of our provider areas and the key areas of financial performance. In that area, we're sort of highlighting that our key cost pressure area is in relation to mental health and learner disabilities. In this area, this will include that cost of private providers as already referenced, plus also ongoing pressures in relation to pay and CHC. Included in the report is the analysis of our agency and locum spend, as has previously been reported in some of the earlier items on the agenda. Pleasing to note that this position is improving. There's analysis in the report comparing current expenditure against previous year's averages, and you will see that the bar column is reducing month on month, and this links into the actions being taken to reduce to hit the targets as stated earlier on in the agenda. Still an area of focus, still an area of financial challenge for us, but pleasing to note the progress, noting the further work and action needed to continue this going forward. Also included in the report is a further analysis around the commissioning position. Worth noting in there is a current year-to-date overspend in relation to the Joint Commissioning Committee. as I referenced earlier, there is an assumption or an action within our plan that position will be brought back to a balanced position with services being provided within the funding allocated. There is currently a forecast overspend in the JCC, and our share of that is included in our position. Also included is further analysis in our private providers in terms of mental health that I've always referenced. Pleasing to note the ongoing good performance in relation to prescribing, where we currently have a number of savings schemes that are forecasting to deliver up to 1.7 million, which is above the 1.5 million target that was set at the beginning of the year. Also pleasing to note that our continuing healthcare position is currently showing a level of underspend. It is worth noting, though, that in our plan we did recognise previous year's growth in terms of numbers of packages and the cost of those packages. So there was a funding increase included in our plan in this regard, but pleasing to note that current performance is showing a level of underspend. I'll reference the savings table, which we included in the presentation earlier around the annual plan. In the table in the report, it references a 17.3 million green and amber schemes against a 23 million target, but noting that, as I updated earlier, the further £900,000 that's been identified, which takes us to an 18.2 million current green and amber scheme delivery against that 23 million pound target. We do continue to monitor a number of risks against our plan. These are also included in the finance report. So worth noting that within our current forecast of 23.8 million, £28.3 million, it's included in that the risks that we need to mitigate, and they've already been highlighted. Excuse me a second. I think they are the key points to note, Carl, and happy to open up for any questions or comments.
Thank you, Pete. As always, a really accessible report and a very helpful and succinct summary from yourself. So much appreciated. Steve Elliott, please.
Thanks, Pete. I think we touched on the issues relating to the overspend in the annual plan conversation and the points that Mick raised around concern about making sure that we address any risks on a timely basis. So clearly we'll want to monitor quite closely over the next month or two that the shortfall in savings is being addressed. Just a couple of points from me, really, or a couple of questions, really. One is that in respect to the mental health private providers, the forecast, if I understand it from the previous slides, and is for a 2 million overspend, but at month 3, in terms of, I'll just get the right slide, one of the slides, slide 5, I think it is, that you're currently only showing a £200,000 overspend. So where's the trajectory there? Is that £200,000 reflective of the 2 million overspend over the year, or is that an improvement to the previous position? The second question really relates to commissioning, and particularly with Welsh providers, where that the Cabinet Secretary allocated an additional £120 million to address waiting times across Wales, and I think we've only received a small amount of that. That hasn't come through on a population basis. So I just would seek assurance that work's underway just to track that Powys receives a fair benefit from that that funding through its contracts with other Welsh providers. Thank you.
Thank you, Steve. So in relation to the two items, the first one for mental health providers, in establishing our financial plan for this year, we included the last year's outturn position of circa 4 million as a sort of funding assumption. Currently, that is showing a potential pressure of 2 million in terms of the 6 million that's included in the individual slide within the reporting pack. That also links back to the £2 million worth of mitigating actions that we're targeting to deliver and bring that back into line. Where that line shows of 200,000, there are some other areas included in that subheading. So it's not, there's a little bit of netting off across other areas, but the forecast is as per previously stated. in relation to the funding that's being allocated in terms of additional performance, that may be something that Nick will want to add a comment on, but we are clearly monitoring activity, ensuring that we're not charged for activity that's already been funded. But that is a very complicated position and something that we're spending a significant amount of time to be as clear on as possible. I'm not sure if Nick would like to add further comments on that one.
Yes, thank you. I think for noting for the board, it is worth noting that we did mitigate as far as possible the impact of additional activity funding through central plan care monies across Wales in our agreed long-term agreements with those providers. And we continue to operate those mechanisms. I think it is worth noting that money is not applicable to Welsh patients waiting in NHS England, and the board will be very well aware from our performance reports that we actually have more patients waiting in England from our population that we do in Wales. So I think in terms of factual accuracy, it's worth noting that. Thank you, Steve.
Thank you. Ronnie, please come in.
Thank you, Carl. As others have said, Pete, this is, as always, a very helpful report. So I just want to acknowledge that to you and your team. The issue that I want to raise particularly is at 5 of 19, vacancies running at 22% for MH and LD and 14% for community services. In total, that's somewhere over 250 posts. I just wanted, if I may, to get a sense of what we're doing about that, if anything, and how we balance that dynamic against our wish to reduce headcount generally. Thank you.
So thanks, Ronnie. So clearly we've got a significant programme of work in terms of recruitment, including overseas nurses, the aspiring nursing programme and other such initiatives which the board will be fully aware of. And clearly then it's just a balance between that other work in terms of making sure that essential areas are filled as timely as possible. I'm not sure if Deb may want to add anything further around that.
I can see, Pete, that Elaine is offering to come in with a comment.
Elaine,
so Elaine, please do. And then Deb, do come in after Elaine if you have anything to add.
Yes, thank you, Ronnie. I'm Elaine Lawton. I'm the Exec Director of Primary Care Community Mental Health for the Health Board. In terms of those vacancies that we're carrying at the moment, both in mental health and learning disability and community services, there's a number of activities. So there's significant amount of work that is ongoing in relation to recruitment. That may be recruiting locally, that may be some of our international recruitment as well. And we have a significant amount of our agency coverage is supporting those vacancies, particularly in areas where we can't reduce the workforce because of the need to ensure that our care for patients is safe. I think there's a larger piece here as well, which is how we build this into our Better Together programme. So as we're looking to the future and considering what we need our service model to be, also then considering what we need our workforce model to be to support that and to support that in a safe way that is also recruitable. There's a significant amount of really positive grow our own initiatives in place across both of those services, but it does remain a day-to-day challenge.
Yeah, do you have anything to add?
I think, just till I wait, somebody going to put me, thank you. So agree with everything that Elaine said. Elaine, myself and Claire, amongst others from the teams, are working really hard. We've seen the success of our international educated nurses. We've just received additional funding from HEIW for this year for the next cohorts, including two doctors. But the numbers started to come through now from our aspiring nurses means that our trajectory is looking like, particularly on adult wards, that we're actually close to eliminating the vacancies that we will all remember talking about 2 or 3 years ago. So the balance is changing. So it gives us greater opportunity now to start to be really quite determined to remove all agency as wherever we can. We've got some exception criteria, of course, but yes, so quite positive.
Thank you. May I just come back on that slightly and say that I don't doubt there's lots of activity going into this locally. I understand that, of course, and I acknowledge it. But I just wonder, are there any lessons that we might learn from elsewhere as to how the vacancy, given that some vacancies, you say, Deb, will be naturally expunged anyway as a consequence of local initiatives. But for the other areas, are there any exemplars that we could draw on from elsewhere?
I think we've looked across at what others are doing. Other health boards will have changed some service models, therefore bringing teams together, thereby creating greater resilience. We know that all of that will be part of options and considerations in terms of better together. What I think we've done, I can't comment on all other health boards, is that we have been keeping a close eye on our trajectory, so we're not in a position where we've commissioned places and then we can't place those individuals. So we benefited this year because of a surplus of trained RNs coming out of university. The health boards weren't able to pick up some of those individuals, so we've benefited from 2 or 3 coming to Powys. So we'll continue to watch what others are doing, Ronnie, but I think some of that is already baked in.
Thank you.
Thank you. We go now to Mick.
Thanks, Chair. So, I mean, obviously, the £1.4 million overrun against the profile at the end of the quarter is a matter of concern. But what I find quite reassuring is that what appears to be driving that is different than the cost pressures we were wrestling with last year. Particularly CHC and agency spend and social care spend, and that suggests very much that the action you've been taking has been impactful. That's to be commended. And I think that's quite reassuring. But my question is that £1.4 million pressure, is that likely to level off as the commissioning changes take, kind of embed? And is it a one-off pressure which will have to be soaked up as part of the overall budget deficit, or will we recover that or offset it as the commission changes set in?
So based on the action that's been identified, we should start to see that improve as we go forward. I think for the remaining months of the year, I think the important point to come back to, which is slightly related to your point, Mick, is that remembering that at the moment we've got 18 million identified against our 23 million target, so there is a gap still there. That is still a risk that we need to close to deliver our forecast. I think that's a key thing just to emphasize. But we will then see that position, if delivered at the level we expect, to flatten going forward.
But will that £1.4 million that we've overspent so far, will that won't be recovered now? That's spent, and that will add to the pressure.
Yeah. Yes.
Okay. Thank you.
And Kirsty, please.
Yeah, it's following on from that, really. I think the team is to be commended. We are seeing improvements in some of these areas that have been long-standing issues for us as an organisation, which is very welcome. But we're also seeing new and emerging risks. So I'm just concerned about, whether we have, what intelligence do we have that some of the emerging risks around a shortfall in national insurance contributions, the risk pool increase, the JCC commissioning increase, and the band 2, band 3 issues, they are in the paper as potential risks. But I'm just wondering whether we have any intelligence about whether some, all, or how much of that might land on us in the year, because not only do we have the additional 1.7 that Mick just talked about, we've potentially got these emerging risks that will actually land on us as well, which will impact on our ability to meet our plan, let alone go beyond the plan.
Yeah, thanks, Kirsty. So those risks are closely monitored. As soon as appropriate are brought into our position on a year-to-date and forecast basis. I think that also does link back to the earlier conversation. So the additional 2% savings target that we've set the organisation, all that action, the first call on any benefits that deliver is underpinning our current plan, maintaining our forecast at the 28.3 million. And that is for the reasons you've highlighted. One, to cover any shortfall in terms of savings delivery. Two, to cover any emerging cost pressures against that plan. And three, to help mitigate any emerging risks and financial consequences. So I think that's how that links back. And they're important points which we closely monitor and, as I said, bring into the position as and when relevant.
Is that okay, Kirsty, or do you? No. So I'm assuming, Kirsty, that you're content, and but please do come in again. Yeah.
No,
okay.
That's great.
Thank you. In which case we go then to the recommendation against the financial performance report. That's that we receive the report. We take assurance that as an organisation we have effective financial monitoring and reporting mechanisms in place, and that we consider and discuss the financial forecast for 25-26 of £28.3 million and the underlying deficit of £42.1 million. Do indicate, please, if you want to comment on or you don't support any aspect or all of that recommendation. That, therefore, is supported unanimously. Which brings our attention to the Integrated Quality and Performance Report, the IQPR, as it's often referred to, and we go back to Nicola to present this to us. Thank you, Nick.
Thank you, Chair. So I'll present it in highlight format, presuming that members have read the report. So in terms of key measures as for Powys Teaching Health as a provider, we are maintaining good performance in the 104 and 52-week planned care measures, in the measures around waiting times in our minor injuries units, all the measures around adult mental health, and intervention and children and young people's mental health, and intervention and assessments for adult mental health. Areas which are noted as not meeting the measures at present are diagnostics, where we still have patients waiting over the waiting time standard, and those are increasing little by little on month during this year. We have had central planned care monies from Welsh Government to help us address that waiting time, which we're targeting at the echocardiograms, which is our particular problem. And we expect that target to be back in balance by the end of Q3. In terms of therapies, very unusually, therapies didn't meet the 14-week waiting time in this period due to workforce issues, which are outlined in the report, and in the detailed report, again, services expecting that to improve during July. In terms of the CTP and the psychological therapies in mental health, same issues apply. There is an improving situation, but obviously due to the small nature of those teams, some fragility in meeting those targets month on month. With regards to neurodevelopmental services for children and young people, we have maintained the 104-week waits in this period. The service remains in escalation. However, we will be considering, we considered the internal escalation status of that service at Executive Committee, we'll be having that discussion with the next PECS committee as well. Returning to Commission services, in this report, we're still reporting though that there's longer waits in NHS Wales than in NHSE for planned care, although a small number of health boards achieving the NHS Wales standards for our patients. Obviously, from July reports onwards, we will see that the NHS England waits, particularly in the providers that we discussed earlier, will start to even out with the NHS Wales performance frameworks, and we'd expect to see that in these future reports. We have a cohort of patients waiting over 104 weeks in Robert Jones and Agnes Hunt, and in our LTA agreement that we're close to agreeing with that provider, we will continue to have a cohort of spinal patients waiting over 104 weeks in that provider. As we noted under the finance report, unfortunately, the central plan care monies do not come to us as a commissioner, and we're not able to use those to support a reduction in that cohort. Cancer performance remains variable in commission services, as outlined in the report. And again, as the board is very familiar with, A&E waiting times in Wales remain slightly better than in England. So that's the summary of the report, Chair. Happy to take any comments or questions.
Thank you, Nick. Colleagues, please indicate if you'd like to comment. Nobody's indicated. Nick, could I just ask that you mentioned the Robert Jones Agnes Hunt, because the spinal delays have been there for quite a while now. My understanding is that that was because of some capacity issues that Robert Jones Agnes Hunt were having themselves, rather than any financial matters from our perspective. If that's the case, I mean, what level of confidence do we have? Because it seems to be quite a prolonged matter.
Yeah, we expect, due to the capacity issues, which are partly due to the amount of resource that those very complex operations require in that spinal cohort, that capacity issue we expect to continue throughout this year. And our agreed LTA presumes that there will be 50 spinal patients waiting over 104 weeks in that cohort at the end of the year. The financial issues play in that NHS England for that cohort is commissioning additional support from other providers. But obviously, because we don't have those central monies allocated to us on a commissioner basis, we're not able to do that for the Welsh patients, unfortunately.
Thank you. So there are no other contributions, so we turn to the recommendation for the IQPR, which is that we receive and discuss the content of the report, and that we take assurance that the Health Board has appropriate systems in place to monitor performance and to respond to relevant issues. Our usual way of dealing with these recommendations, please indicate if you don't support the recommendation. That too is supported, which takes us to item 3.14 and to Helen, who will speak to the risk appetite statement. Colleagues will remember that we did consider this back in May, and we asked for a bit of further work to be done, particularly on the financial risk. That work has been done, and it has been considered in some detail by the Audit, Risk and Assurance Committee, and it's that's brought back to us today for our consideration. So over to you, Helen.
Thank you very much, Carl, and very pleased to present this back to the board. I've drawn out in the cover paper that additional work that you just referred to in terms of the financial categories, but for completeness, the full risk appetite is appended into the report as well. So as you rightly said, Carl, we've worked with both of those committees and we have arrived at a conclusion where essentially, instead of having one category for financial sustainability, we have now separated it out into 3 areas. And as you'll see in the report, we are recommending that financial governance carries an adverse rating or appetite, sorry. Financial sustainability carries a cautious appetite, and financial investment carries an open appetite. And that open appetite is particularly in the context of supporting the Health Board to improve its financial position. So as we know, the risk appetite is here to help guide our risk management work and the decisions of the board, and provided back today asking the board to now accept and approve this amended risk appetite statement. Thank you, Carl.
Thank you, Helen. I wonder, I'll just invite Steve Elliott, Chair of ARAC, and also Ronnie, Chair of Finance and Performance Committee. Both of those committees, as you say, Helen, have looked at this. If you do have any additional comments, please come in. Steve first.
Yes, thank you, Carl, and yeah, just to support the paper that Helen's just outlined. I think we did consider the financial risk at length in ARAC on 2 occasions, and I think the suggestion about splitting the risk into 3 sections, which I think is consistent with which at least one other health board has done, seemed to be the best approach. I think the appetite around financial sustainability as a cautious risk rather than as a minimal risk probably reflects where we are in terms of our current annual plan and planning position. So we were happy as ARAC to recommend this to the board. Thanks.
Thank you. And Ronnie?
Thank you, Carl. I think the committee which I'm privileged to chair was also content as to the way forward on this. I think I've made the point to Helen previously that none of this is set in stone, and will be subject to further refinement as we go along in the light of prevailing circumstances. But for the moment, I think it is essentially a good risk appetite statement as to where we are in the present day. Thank you.
Mick, please come in.
Thanks, Chair. It's a broader question, really. You know, as a statement of appetite of the board, I think it's fine. You know, it's something that we kind of worked on together. But as I read it, just occurred to me, well, what difference does this make? So, you know, it kind of guides our thinking and our decision making as a board. But it does. You know, how do we operationalise this? How's it kind of spread down through the organisation so that, you know, people at executive level, senior leadership level are making consistent decisions which align with the framework that we've set?
Helen.
Thanks, Mick. Thanks ever so much for the question. Quite right. I mean, we've obviously developed this as a joint board, so the executive team have been wholly involved in that. And increasingly, what we're trying to make sure that we do is risk appetite forms part of all of our not only documents, but our thinking. So when in the next item, when we consider the strategic risk register and the board assurance frameworks, you'll see that risk appetite is embedded into that. And we're starting to make some assessment and offer the board some commentary now about whether risks are operating within or outside of appetite, as an example. That over time, and it will take a bit of time, that will then spread through to directorate risk, programme risk, and the infrastructure that we have operationally within the organisation to look at how we review risk and how we manage risk. So there will be a training package that supports the new risk management framework as well, and it will form part of that. So it will take some time in reality, but I think we've started at the right point, working top down to make sure that we embed it as far as we can. Thank you.
You content, Mick?
Yes, thank you.
Okay, thank you. We go to the recommendation, which is that we receive and approve the revised board's risk appetite statement following further refinements to the categorisation of financial risks as supported by our Audit, Risk and Assurance Committee and the Finance and Performance Committee. Again, please indicate if you dissent from the recommendation. That therefore is supported, which takes us to the Board Assurance Framework and Strategic Risk Register. We're back with you, Helen. I'm very conscious that this is a kind of first outing, particularly for the Board Assurance Framework dashboard. And so we will need to mature it, to start implementing and embedding it and learning how to use it and what it means to us, really picking up a little bit from Mick's question just then. But so please introduce it, but I'm just acknowledging as to where we are with this, really. Thank you.
Thank you, Carl. That's really, really helpful. And I'm delighted to bring this to the board today. As you will all know, we've been on quite a journey with our broader board assurance framework, risk management framework, and all the supporting tools that come with it. So I'll just give a brief introduction to both the strategic risk register and then the board assurance framework dashboard. And then any more specific questions that are received in terms of the detail of risks themselves, I'll also invite senior risk owners in if and where appropriate. So just in terms of the strategic risk register, then this was a fundamental change in the board, in the risk management framework that the board agreed in March. In May, you considered as a board the 13 strategic risks that we'd outlined as descriptors, and now this is the further developed version of the full strategic risk register. You'll note from the paper there are now 12 risks, not 13, and that as we've developed the detail, the risks in relation to provider services and system resilience were too close to be two separate risks, so we've moved those together. So Appendix 1, which is paper 3.15a, provides the full detail of those risks. You will recognise the template that we developed over the last 12 to 18 months, but we further enhanced it. And just to confirm, Carl, each of these risks will continue, as per our framework, to be reviewed in greater detail by each of the relevant committees for which they will seek assurance from all of these as well. You'll note from the paper risk 11 on our digital and cyber network is considered in committee, given the sensitive and confidential nature of some of the detail, although the scores and the BAF ratings are included in the public papers. The organisational risk register, which will sit at executive level, is now well in development, and in future board papers that will form part of the information pack for the board. So you have full sight of both strategic risk and operational risks that are managed through the executive team. So this will next be presented to the board in November. We took a decision in our risk management framework that we would present this 3 times a year, unless there is a different need, of course, and we'll review that. But for today, the board is asked to approve the strategic risk register and adopt that into the organisation. The second part of the paper then is the board assurance framework in terms of the dashboard that we've been developing. And you may recall that when we approved our board assurance framework document 12 months or so ago, there were 3 component parts to that. One was the quality and performance framework that Nick has just presented 2 items ago, and that updated framework was presented in and approved by the board in May of this year. The second part of the board assurance framework was our overall system of governance, and we are developing some dashboards that they will appear a little later to the board. But of course, earlier in the agenda, we received our annual accountability report that was subject to external audit, and that provides a level of assurance to the board. The third area then, and the area that we've prioritised for today's board, is our risk management dashboard, and this is the second attachment in the paper, 3.15b, and this is the first time the whole board has seen this, Carl, as you rightly said. We've looked at some of the templates through the audit and risk committee, but not the full detail, and as I said, it's the first time that you can see the full dashboard on a few slides that essentially gives you a more detailed overview of our risk assurance analysis, and essentially over time tells us how effective our strategic risk management is supporting the delivery of our strategic objectives. It reflects to you where risks are operating within appetite. It talks about the adequacy and effectiveness of our controls, and also the associated assurances that support those controls. We will continue to develop and mature with this. This is absolutely the first time that you've seen it. This is really about us approving the approach to this. There is the detailed content is there also. And as and just thinking back to Mick's question in the earlier item, as we move forward into future board meetings, we will start to be able to incorporate the analysis and messages that are coming from the board assurance framework into some of the other papers and decisions that the board are asked to take. So we start to triangulate this information together. So as always, risk and board assurance frameworks are here to help guide the board's decision making, but also to provide you with some assurance in the context of your role as a whole board, and particularly in relation to our risk management systems. So again, Carl, the board's asked to approve the board assurance framework dashboard today, and we'll then embed that into the organisation and future board reporting. Thank you.
Thank you, Helen. Colleagues, please do come in if you have any comments, questions in relation to this paper. Really good to see the particularly, well, to see everything, but I think the BAF dashboard is going to be really helpful. As you say, Helen, there are issues on it, such as how do we tolerate the gap between risk appetite and the actual measured risk? Not for discussion in detail today. It's more about does this kind of dashboard, is it something that we recognise as something that's going to be helpful and useful, and as Meg says, practically implementable within our work. So we will go to Jen, please.
Thank you. Sorry, just getting off mute. Helen, this is a masterpiece. Goodness me. Incredible set of documentation, and I congratulate you and the team for pulling all of this together. And I know that, as others have said, we've been involved in some of the formation of this, which has been incredibly helpful, because there's an awful lot in there. I just wanted, and Carl, you may have just referred to this, but I just wanted to have a look at, in that summary position, about in slide, what is it? I think it's slide 5. You know, there are three out of 12 risks received are operating outside the board's risk appetite. So that is, what are we doing about that? We're not needing to address that today. We're looking to note that and then reflect on that position in future discussions. Am I correct in that? I'm sorry if I've missed it, but I'd just like some reassurance on that, please. Thank you.
Helen, would you want to respond?
I will. Thank you, Jen. Thanks ever so much for your feedback, and I pay particular credit to our Deputy Board Secretary, Stella, who's done some incredible work and really pulled this together for us. Thank you for the question on those 3 risks outside of the board appetite. You're absolutely right, Jen. I mean, in effect, the controls and the actions that are within the strategic risks should change that position. It should come into appetite, and if it can't come into appetite, the board would then be asked to review that and make a decision as appropriate at that point. For today, it's a position statement, really, and from now we'll be able to develop a set of data and narrative and analysis that will help us to keep an eye on that and review it into future board meetings. So no action required today, almost a statement of position to help us move forwards.
Thank you. So Steve, please.
Yeah, thanks. And just want to echo, you know, the amazing work done there. And I think we, you know, this is a great progress, a great way forward. Obviously, I think there's a lot of tweaking to continue, but really look forward to using this, you know, in anger, as it were, going forward. Can I just ask one question? And it doesn't necessarily need an answer now, but I think it's just a flag, really, which is in relation to the strategic risk 008 around the health board being unable to shift to a primary prevention focused healthcare system. I'm just interested in how we really measure, you know, are we clear about what that looks like, and in terms of what we're trying to achieve, and therefore that we're able to measure our movement towards that, and therefore to highlight risks where we're not able to achieve that. And that may be for Mez to respond to, but it's just something to flag, I think, because it's a new risk, I think, that sort of that we've decided, you know, we brought it into the strategic risk register. So I think how we track that, I think, is going to be quite important and interesting. Thank you.
Thanks, Steve. I'm trying to come up with an Oasis analogy, but I can't. But I agree with you. Mez is the senior risk owner on this one, and maybe Carl, we just want to ask if she wants to make any comments on it. Thank you.
Yeah, thank you. And yes, it's sort of important in terms of we've been talking as a board around that shift left to shift to prevention and also to community. So it is important. I'm sort of pleased really that we are having greater prominence around this element really, and we will be bringing through a prevention framework to board in September as well. And that shift left also needs to be looking at how we provide stronger support within population around community element really to keep population healthier, to delay those chronic conditions which we know that will be coming, and also when they do arrive, how we manage them better. And then around that we will be putting some performance metrics as well.
Thank you. That's really encouraging, Mez. I think you know, you and colleagues presented information to us in a board development session not that long ago, and emphasised with us the importance of primary prevention. So, you know, really look forward to seeing that framework and exactly as you say, Steve, how we are going to measure ourselves in terms of both the benefits and the risks in that shift left journey. So really important point. Thank you. Ronnie, please come in.
Thank you. Helen, as others have said, I think this dashboard has the potential to be very, very useful. And I just want to acknowledge the work that's gone on around this. For my question, I'm reminded of the quote by A.A. Milne: when you think of a thing inside you, it seems very thingish. When you bring it out into the open and it's looked at by others, it seems very different. So my background here is on page 5 of 8, 10 of the 12 risks are operating within the board's risk appetite, but 3 of 12 are operating outside the board's risk appetite. Is that tautology or is there something wrong?
It was a check you'd spotted it, Ronnie, at 9 of the 12. I think because we've moved from 13 to 12, I think we've had a slight mathematical challenge there, but we'll pick that up and make sure it's corrected. There are definitely 3 operating outside of appetite. And just to quickly add on it, Carl, actually, if I may, one of the points Mick raised with us in the Audit and Risk Assurance Committee is, you know, what are the operating principles that sit behind this? How do we make the analysis of what's in and out of appetite, or what's a reasonable or limited assurance level? And just to say, we have developed almost an operating manual and a set of principles that sit behind this that we'll share with the board separately, so you can see some of the method, if you like, that's applied to understand it. Doesn't solve the mathematical problem, Ronnie, but we'll correct that. Thank you.
Thank you.
Thank you very much. So so we will go to the recommendations, and that is that we discuss whether the risk register accurately reflects the Health Board's current strategic risk environment, and that we improve the document for formal adoption by the board. We also discuss the newly developed Board Assurance Framework dashboard, and that we approve the document for formal adoption by the board, and that we note that one of the risks, on the strategic risk register number 11, will be considered in greater detail when we meet later today in the in-committee meeting. Please indicate if you don't support or approve the recommendation or any part of it. That also, therefore, is approved unanimously. Thank you very much, which takes us to the report of the Regional Director of Llais, and we're back with you, Katie.
Thank you, Carl. Just a couple of things from earlier papers and discussions that might be useful observations. Firstly, with regard to the engagement for Better Together, we attended every single session, I think with the exception actually of Newtown. And I think the key for us, and obviously for you and the team, was ensuring that that process was meaningful, and people have noted that the discussions were very, very positive. I think one of the things we've picked up with Helen and the comms team really is about looking at other ways of engaging with communities and the potential over-reliance on digital engagement, which is is great, but equally we know, and it's very appropriate in a rural area, but equally we know that there are people who are excluded from that form of communication. So I think going forward to the actual consultation, we've said that we're happy to sort of support and look at that sort of engagement program going forward. Goes back to Chris's point about schools, and Facebook we all know is almost out of date for a lot of people these days, and so it's looking at the other social media avenues as well, and everybody including ourselves struggle with that, so it's not unique in any way, but it is something I think to ensure that as many people are engaged and it is a meaningful engagement. The other thing that I just thought might be useful to pick up is on the maternity services. I have included in my report the response that Llais made to that situation, and all regional directors have written to their health board seeking assurances around the impact or the potential impact on residents of their communities. I think I'm sure everybody agrees, it's really, really disappointing and actually quite sad that this has happened again following Sath and Cwmtaf Morgannwg, and at some point, one of the things we're keen to do is to make sure that lessons really are learned and that families and individuals and carers and babies are not going through this process. So just to make you aware of that, and it was helpful to note that about the clinical, the strategic commissioning framework at the discussion at the next board meeting. I think from the report perspective, I think it's hopefully fairly self-explanatory. Just a couple of things that stand out a little bit, I suppose. We're finding that more and more people are going privately now. We're actually asking people in all of our sessions if they're comfortable to share with us whether they are accessing private services. That's not unique to Powys as well, but it's just something that we need to be aware of. I think we've had a couple of comments through the work that we've done about Llanidloes Hospital, and so again, when looking at that temporary service change, about potentially looking at any unintended consequences that might come from that. And I think we're sort of picking not a lot of noise up, but there does seem to be a little bit of noise on that. The big thing, I think, apart from access, obviously, is around communication and alignment with other stakeholders, and again it was touched on earlier with care packages and people knowing what the next stage of their pathway is and where their pathway is and what their pathway is. So again not unique to Powys, but when we're all looking at some of these fundamental shifts going forward, something that I think needs to be at the forefront, and I know it is. And I think finally, one thing that I didn't put in my report is that we've just also launched a new project on rights, expectations and responsibilities. So that is trying to understand whether individuals are aware of their rights, what their expectations are, and what the responsibilities are on the public sector. And that's a national report across the whole of Wales. So I'm happy to pick up any points following that, Carl, but I'll hand back to you.
Thank you very much. So colleagues, please do indicate if you'd like to ask anything or respond to anything in Katie's report. Just whilst people are doing that, Katie, you often and invariably offer us assurance that that there's really rich and important information in all of your reports, but that you do have opportunities with executive directors, with managers and officers across the health board to pursue these. So we don't just receive them, say thank you for them, and everything goes away, but that those issues are pursued, and in a spirit of continual improvement and so on. I'm assuming that that's the case, unless you tell us otherwise.
No, it is. I meet fortnightly with members of the executive team, and regularly if there's a specific need to meet around a particular area. So yes, just to provide the board with that assurance, I'm very comfortable and confident that we've got the systems in place to work our way through some of the findings.
Thank you. Claire Roche, please.
Thank you, Chair. Thank you, Katie, for the report. I always find it extremely interesting to read your reports. I've just got two questions really that relate to what's described on page 3 as themes from complaints. The first question is that some of those points are really quite specific, and I just wondered if it was related to an individual particular experience, or whether actually more than one individual has had that experience and therefore it is being drawn out as a theme. And then the other thing I recognised in there was some concern around delays in the handling of complaints, both from whether that's NHS or local authority. And of course, we have worked incredibly hard to be able to respond to formal concerns in a timely manner. So not necessarily for discussion here, but just wanted to ensure that if there's some learning there for me and my team, then absolutely content to pick that up. Thank you, Katie.
Yeah, would you like me just to come back on that? Is that okay?
Yeah. Yes. Of course. Yeah. I mean, it may be, as Claire says, that this is going to. Yeah. But anything you want to say in this context, please do, Katie.
Just to say, Claire, we're meeting with your new member of staff. You referenced her earlier. We're meeting with her tomorrow, so that's that's going to be a great way forward. I just think everybody's incredibly busy at the moment, and the pressures on complaints. Our complaints are increasing, and that's the situation. But I'm happy to pick that up outside of this meeting. With regard to themes, it's a really difficult one with themes, isn't it? Because actually, if one person has had the most awful experience, the fact that only one person's had it doesn't make it a less awful experience. So we do pick up themes. We've got some quite big themes going on in primary care at the moment, for example. So we will pick up themes. But again, we have those conversations with you and your colleagues as an executive team, particularly if it's becoming a trend as well as a theme.
Thank you. Mick, please come in.
Thanks, Sharon. Not so much a question for Katie, more of an observation, really. Yet again, Katie's report highlights people's concern about transport and travel being a barrier to good healthcare. And in previous reports, she's also highlighted other things like digital, and all those things are outside our direct control. And it was a real strong theme of the community event that I went to. Everybody around the room had an issue with transport and access. And it just strikes me that this is as we move towards making decisions and going to consultation about Better Together, this is going to be a significant barrier to some of the things that we need to do on behalf of our communities. But if these things could be addressed, they would be a significant enabler to maybe more imaginative and more forward-looking solutions. So I just wonder what we are doing as a health board to kind of engage with those who can address these things. And they're really difficult and intractable situations. But I think unless we are thinking about how we tackle those things, then it's going to make Better Together more difficult.
Thank you, Mick. Katie, do you have a response? It may be that Hayley. Hayley, I can see your hand up. I mean, there's the role of the PSB in some of this as well, I think. But Katie, first to you.
Yeah, I mean, you're absolutely right, Mick. It comes up everywhere. I was in Machynlleth at the Health R event and it came up there again. I think there are some things that can be done to make it easier. The timings of appointments make it a lot easier. Not having to be in, I don't know, Aberystwyth or Bronglais for 7 o'clock in the morning. I exaggerate slightly to make a point, but I think there are some things that can make people's experience much easier. And again, I think it's about working closely, and I know you do, but with the local authority, and we've picked up that there's a bus. I mean, there aren't that many buses in Powys, which is actually one of the stops has been removed from that bus. Now, that's not your role, but actually from a PSB or an RPB perspective, that is a conversation that potentially could take place. So yeah, I'll leave it at that. It's not one we're going to solve this afternoon.
Thank you, Katie. Hayley, please.
It's a really important point that Mick raises, which is particularly acutely felt by our population because of the rurality and the distances that individuals travel, both within the county but also out of county on the pathways of care into our neighbouring hospitals. It is a theme, Mick, that is coming across all changes across all health boards, but particularly for us, a couple of things. Travel times assessment is part of the methodology in looking at any future options, so we really understand the impact. And then the question of what can we do instead, or how can we help mitigate that conversation with the local authority about within the county, but also more generally involving colleagues like WAST and looking at it from a broader third sector community transport perspective as well, is something that I've found in any of the changes we've looked at. We've had to put some mitigation sometimes in place, which is there's no one solution fits all, but it's a number of sort of steps that we need to take. But I think it's an important point, and one in particular for us that is probably one of the strongest themes that come through from our population. So I'd be keen for you to be assured as a board that that is part and parcel of the impact and also the options that we'll be looking at going forward about how we can address some of those key issues that our patients are experiencing currently.
Thank you. So thank you for that, and thank you, Katie, as always, for a really, really helpful report. So we move to item 4 of our agenda. I should say that the recommendation is that we receive the report from Llais, which I assume that we do, unless anyone indicates to the contrary. Therefore, we do. Our consent agenda at item 4, as I explained earlier, we receive and we approve those en bloc, so there is no discussion about any of those items. There isn't any other urgent business, and therefore that concludes our meeting and our business for today. We next meet for our AGM on the 15th of September, and then for our next scheduled board meeting on the 24th of September. But for now, it just remains for me to thank everyone who has prepared so meticulously for this meeting, and therefore supported the very smooth running of this meeting, for everyone that's presented the information, for all colleagues for participating in the discussions and the conversations and the scrutiny of the information provided. Much appreciated. And that's all for today, and I bid you all a good day. Thank you very much. Goodbye.